Welcome to the Healthcare and Wellbeing Overview and Scrutiny Committee. Today is Tuesday, 30th of September. We don't have any notification of any fire drills, so you all know procedures if it does go off. So can we first of all have declarations of interest, please, from members? Anyone? Councillor Boynton.
It's just my non-pecuniary for working with Humber NHS.
Thank you. Anyone? Councillor Walker.
Non-pecuniary interest, Chair, and that I'm a trustee of the Bridlington Health Forum.
Thank you. Councillor Owen.
Thank you, Chair. Just as Chair of the Health and Wellbeing Board. Thank you.
Thank you. So can we have a proposer and a seconder for the minutes of the last committee, which was held on the 9th of September, please? Thank you, Councillor Cousins and Councillor Boynton to second. Thank you. So we have our update today on the Discharge to Assess programme. I think we're going to go to Councillor Owen to introduce this first. Thank you.
Thanks very much, Chair. Very little to say. I mean, it's the latest update on discharge to assess for people leaving hospitals. And I think I'll carry straight on to, I don't know if Simon's going to lead on this, but hand straight over to officers and maybe comment later, but much more, I think, for the committee to question.
Thank you. Thank
sides.
you.
Thank you.
Thank you. Yes. So welcome. I'm Simon Cox, Place Director for the East Riding and the ICB. So the large majority of the work of this and most of the detail that people will take you through will be led by Rachel Kemp to my left, and then Liz from Adult Services will then bring the local authority perspective in. So without further ado, I'll hand over to Rachel, if that's okay.
Good morning, councillors. Rachel Kemp and I work across Hull and East Riding in a kind of joint post supporting discharge transformation programmes. In terms of the report, I'll take you through some key points and then hand to Liz and hopefully pick up any questions. But in summary, the Discharge to Assess programme aimed to deliver three key components really over the past 12 to 18 months. And we talked a little bit about that previously when we met. And the key components really were an integrated discharge team, which included all partners across Hull and East Riding, that aimed to effectively triage requests for support for discharge and deliver those in a safe and timely manner. Additionally, it was about bringing together the services within that integrated intermediate care tier, so home care, reablement, community support and intermediate services in embedded rehabilitation units, so that those that required home first services or services that would keep people safe and well in the community could receive those in a much more timely manner. And additionally, we've worked really hard. Thank you. Additionally, we've worked really hard on a shared view of data so that we better understand how well we are performing, where our areas of challenge are, and hope to address those. In terms of its delivery, the programme has delivered significant improvements over that time, and we have delivered a number of those components that I've just described. I think the only area where we've worked still to do is that integrated home care offer. At the moment, we deliver siloed reablement services from each organisation that forms that home care offer, and that would be the area of focus that we'd look to pick up in the coming months. I think we've also enabled a much greater degree of assessment capacity and the delivery of safe and effective services for people to receive support at the time that they go home. Picking up on some of the performance outlined in section 2, as I've described, we have significantly improved our ability to understand what we are doing, how well we're achieving against a number of different areas. And figure 1 describes the specific performance for East Riding in discharging patients from Hull University Teaching Hospital. You'll note that there is some degree of variance across that period, and that graph describes the position between September 2024, the last time we were here at this committee, and August 2025. The target for East Riding per week is 60 discharges, and of late, certainly since the period of July, East Riding have achieved that required target. In terms of people leaving hospital and the outcomes that they achieve at the time that they leave hospital, figure 2 describes the outcomes in 24 for the period 2024-2025. And the highest majority of people at that time were leaving hospital with no support or informal services, so not statutory support delivered by a local authority or by community health services. And the second highest majority were for people receiving home care or reablement through either community services or local authority or a combination of both. And a key objective of the Discharge to Assess programme was to ensure that more people could go home. So instead of people going to bedded opportunities, we were seeing a higher proportion of people leaving home, leaving the hospital and going to home or with no support. Moving into figure 3, this describes the 2025-2026 position as it stands. And what we're seeing is a shift towards more people going home. So that has now become the highest majority, whereas previously it was people going home without any statutory support. We also see a slight reduction in the volume of people who are leaving hospital and going to a bedded services. And that's a positive swing for the programme, because that was a key objective, to make sure that more people who needed reablement could receive it and could go home at the point of leaving hospital. What we are seeing in the numbers, or what we would probably have hoped as a key objective, is that the biggest majority swing would be away from bedded services and into reablement or no formal support. What we're seeing is an increasing demand and more people going home, but less people receiving no services or informal services. So that either suggests that there is a higher acuity, or people are more poorly and need more support at the point that they're leaving hospital, and we're not necessarily seeing less people going into bedded services. It's only changed by 1% in the two combining years. The other thing that the figures describe, so as it notes in section 2.5, there are more people leaving hospital. I've just described there's a general demand increase, and that is currently looking at an increasing rate of 6.5% between previous year and this coming year. And the specific shift has been into that home care reablement offer. Moving down the report, again, we're looking just at the numbers last year to this year. There is that projected increase in demand is also indicating that 6% shift of increase. So year on year, that position has increased. We now need more reablement support than we did previously. There's still a significant amount of people going into bedded services, and that hasn't reduced significantly year on year. So less people need no support, more people are going into reablement, about the same, 1% less are going into bedded services. That's what the outcomes look like at the moment. Moving into section 2.7, this describes how quickly East Riding can assess people and put services in place to discharge people. In the two figures, one indicates the volume of people waiting between, or the days between the point that the person is referred into the discharge hub and then discharged. And this table beneath describes the days between when the person is assessed, so a social worker is assigned to the case, and then discharged, just to describe the two differences. Both tables know that East Riding can discharge patients on pathway 0 and pathway 1, so no informal support, no formal support, and reablement faster than they can into bedded services. And on average, it's 1.8 days from the point that the referral's received for pathway 0 patients, and 5.4 days to discharge a patient into reablement services. Both of those figures have improved from the previous year. And for patients on pathways 2 and 3, so short-term bedded services or interim bedded services or long-term nursing or residential provision, they are taking considerably longer. And we do know that there are in part some brokerage delays, as well as care market availability that is challenging that position. The other thing to note that the two tables provide a position that says it takes at least 1 day for a social worker or care coordinator to be allocated that case and for the person to be assessed. And that's an area where we want to improve, and we certainly have seen significant improvements over the last 6 to 9 months. The ICB has supported the council with additional staffing capacity so that we can reduce some of those assessment delays. One of the key criteria that we measure our improvement against is a no criteria to reside position, and that no criteria to reside metric measures how long somebody waits in hospital when they are ready to leave the hospital. And if you move to figure 5, you'll see that this describes the no criteria to reside position. So how many people are delayed in hospital every day at Hull University teaching hospitals. And there had been a significant trend downwards. However, throughout the period 2024, 2025 and 2025, 2026 to current date, there hasn't been a significant improvement in that period. There's been a marginal shift of 1.9% improvement in that reporting period since the last time we were at this committee in November of 2024. The aspiration for the ICB and the wider national metric is that there are less than 10% of beds occupied by people who are delayed. We currently stand at around 13.9%. So we need to bring that position down by 3.9%, and that equates to around 20 to 30 patients less each day, of which East Riding's component would be about 8 to 10 patients less each day. So every day there are 8 to 10 patients in hospital that shouldn't be, who are the responsibility of East Riding to discharge. One of the other key parts of our programme has been about understanding what we have, what assets we have, and what is it that we need to think about increasing. So in section 4, it describes the robust demand and capacity modelling that we've undertaken collaboratively across East Riding and Hull. And we recognised when we performed the original demand and capacity model in January 2024, it described a significant need to increase our home first reablement capacity. And in response to that, Hull and East Riding and the ICB has contributed £2 million this year to support that enhanced funding. That is also on top of the original Better Care Fund monies that were also supported to East Riding's community support service. So in effect, double amount of funding has been secured to enhance that position in year. We have refreshed the demand and capacity model this year, and in July, the output of that was provided to the system partners. So in figure 6, you'll see that there is a graph that describes actual activity and true demand. So we measure true demand by way of an audit of people leaving hospital. So did they go to reablement when they could, or were they actually moved to an interim service because that service wasn't available for them? And the first part of the graph, the blue is the actual activity and the yellow is the true demand. And you'll see that for Pathway 1, so home care services, we're delivering less than we actually need to deliver for those services. So it is still telling us that we need to enhance the available home care in the geography for East Riding. In other services, they are about where they need to be. So we have about the right volume of rehabilitation beds, and we have about the right availability of assessor capacity. Figure 7 gives an indication of what some of the estimates on that required workforce might be if we were to meet the true demand that we're currently seeing. And I'd ask you to look at figure 7 in section 4.5 and the navy columns there. The demand and capacity model is weighted for population growth and other estimates, as well as what we're seeing in terms of demand. And the grey box describes, the grey column describes where we are currently. And you'll see for 2024, 2028, 2034, there's a significant shortfall in that position in terms of where we would need to be. Moving kind of finally to think about the the challenges and things that have been pulled out of the report in terms of strategies that we need to implement, it is there is a significant degree of improvement, and that's continued since the last time that we were here at this committee, and more people are going home, and that's the right outcome for patients leaving hospital rather than into bedded services. We do need to reduce the reliance on bedded services because there are still too many people going into those services than they need. The demand and capacity model is telling us that we also need to continue to enhance that reablement offer and home care offer. And there are challenges with that, given both of those services are currently supported by the Better Care Fund, of which we don't know what that allocation will be next year. And we'll need to think about, do we have the resources that we need to continue what we currently have? And also, do we have the resources that we need to make to cover the shortfall in where it is that we need to enhance? But certainly the ICB, and I know Simon has already had conversations with colleagues in East Riding Council and other partners across the patch, are committed to making sure that our priority is that if people need to leave the hospital and go home, they should receive those services because it's the right outcome for people and it's the right outcome for the organisations involved. So those are areas that we're currently looking at working with, and Bridget and I have already met in terms of thinking about that wider reablement offer. How do we maximise the assets that we currently have so that we can close that shortfall without just putting a lot of financial resource in it to meet that demand? We also know that in terms of the financial resource and decisions that we need to make, those will be taken through our Better Care Fund governance processes, and we'll do those collaboratively as we move forward. And then the other area, I guess, of priority work is to make sure that we can bring down the delay people experience to move to the services that often people, whilst it should be in the minority of cases, when you do need to move to a nursing placement or a residential placement, it is taking considerably longer, and we need to reduce the time it takes to arrange those kind of services for that minority of patients. But overall, with enhanced assessment of capacity, we are supporting discharges more quickly. We are supporting more people to go home when they need to, but we recognise there is still shortfall that we need to develop over the coming months. And I'll hand over to Liz to pick up the wider geography. Thank you.
Good morning, everyone. I'm Liz Hardy-Cork. I'm Head of Service for Early Intervention and Localities. Just to add to the report that Rachel has spoken to this morning, we also have the Enhanced Hospital team, because we're very mindful that although the bulk of our work focuses very much on Hull Royal Infirmary, Castle Hill and the Huth system, we also face many other hospitals around the patch, and our residents, our patients are located in numerous hospitals across the area, reaching into North Yorkshire and beyond. So we have the Enhanced Hospital team who is set up to pick up everybody who isn't in those hospitals that Rachel has spoken about. This does present us with a challenge because obviously location-wise, it's quite a considerable distance when all of your patients are located in one or two hospitals. So we're looking at, Goole, York, Scarborough, but even further afield, Doncaster and into specialist hospitals also. The teams strive to give the same offer and the same experience and response to our East Riding residents that are located outside of those hospitals. And at the moment, roughly 40% of discharges back into the East Riding come from other hospitals that aren't Huth, although the throughput into the team is not as impactful as through the concentrated work in Huth. Because we've got such a wide geographical footprint, it's quite a challenge to balance the demands and maintaining that throughput of assessments across the site. And they've looked at the workforce within the team to make sure that we're utilising our resources in the best way possible to reduce assessments and discharge waiting time. Whereas the Huth model has an on-site presence, we're not able to do that to every hospital because we simply don't know where our residents will be located at any one time. So, for example, we can't have a team in Doncaster Hospital or Scunthorpe Hospital because we only have one patient in a couple of weeks. So it wouldn't be the best use of our resources there. So a lot of our work we do remotely to understand what the situation is in the first presentation, and that would be over telephone. It could be using Teams to help support that and minimise having that travel time. But of course, if we have to do so, then we would venture out to those localities. The community support service that we've heard about this morning also supports our residents, because even if they're in a hospital outside of the East Riding, they'll be returning to their home addresses, we hope, within the East Riding, in which case the community support service would then be coming into effect and supporting residents there. Excuse me. The brokerage team also supports in the same way, and in terms of those residential settings, we'd be looking at bringing people back to be as close to their family and their localities as possible. And in the report we've said there, about 20% of discharges from the enhanced hospital team are discharged into residential settings. The wider discharge to assess programme, because the teams are all interlinked, they sit underneath one service manager and the two team managers work very closely. The benefits that we've heard about this morning from the discharge to assess programme, those principles have been embedded by the enhanced hospital team. The challenge we have is that every hospital that we work with outside of Huth has their own programme of work, has their own modelling, so that we've always navigating that as well, but bringing those principles back to achieve those outcomes for our residents in the East Riding. It is a smaller throughput, and for example, last week on one day, the enhanced hospital team had 4 referrals in 24 hours compared to the same day there were 16 referrals for Huth, and there were already significantly more cases being worked in Huth than they were in the total sum of all the hospitals outside of the East Riding. So it just gives you a sense of some of the challenges that we're facing if we're not within the Huth system, where we've got this sort of close programme of work ongoing. Just to introduce as well Bridget Cameron, our colleague director of commissioning and integration. She's joined us as well today in case you have any questions around the resources or the commissioning aspects that have been referred to in the report. Thank you.
Thank you, both of you, all of you. So we'll move over to the floor and see who's got the first question. And it's Councillor Walker.
Because I wrote it. Good morning, good morning. Thank you, thank you. When we looked at this December last year, we were very interested in that break between the embedded nature of the whole hospitals and how you would reach out to all of those others. My questions, though, try and sneak 2 in here, please, Chair, are concerned with the patient's view of this as well. The paragraph that first got my attention is on page 10. It's para 1.2. And it concerns the manner in which our adult social care staff operate. The final sentence in there says that adult social care staff serve as advocates for vulnerable individuals, safeguarding patients' rights and preferences, and when necessary, challenging decisions. I wonder if you could talk me through any scenarios where you know that our adult social care staff have needed to intervene, or is that more of an ongoing discussion? Are they presented with something and then need to challenge that, or are they an integral part of that discussion, please?
Thank you. Shall I pick that one up? Yeah. I think it's the ongoing work that we have in the hospitals where The social work team obviously are coming from a very social model view. They're returning people home, they're weighing up lots of the kind of holistic aspects of somebody's life, and hospital colleagues very much are getting somebody well and focused on that. So as a multidisciplinary team, we're working all the time to balance all of those factors. The families coming in, they might have particular views. There might be issues around mental capacity, and the family maybe need to assume a role, might be best interest meeting planning under the Mental Capacity Act. So there's lots of complexity within that. I don't think that comment represents a conflict or a challenge between the health and social care professionals. I think it's the angle that we're coming at in working through those multidisciplinary discussions. And because social care professionals very much will be looking at that kind of longer term integration into the community, because that's their role, they will be thinking about that perspective. So we'll want to advocate naturally to achieve the best outcomes on returning home. But I don't think that describes a fundamental issue in what's happening in the discharge planning. It's just the nature of working in a multidisciplinary environment with different perspectives and achieving different outcomes to that case.
Thank you. Yes, it was interesting to see that we have identified that, though, as a task of adult social care staff from East Riding. But I wondered, could I go on, Chair, just to ask some more of the current operations and to see if these are the aspirations of where we need to be, or whether it is the current way. If, for instance, a patient were referred for discharge, someone was allocated and they were assessed for, say, pathway 1 with some simple reablement there at home, does the discharge happen when that decision is made, or is it when the home support is available and installed? So are we discharging patients expecting some home enablement to be in place, or are they still held within that hospital environment until we know it's safe for them to go home? Thank you.
Thank you. I think anybody who's leaving hospital and they've experienced that period of ill health, there'd always be an element of risk assessment around that. So if somebody was safe to go home, if they had a carer in play, informal care and unpaid care, a family member, then that might be okay to go home at that point, and then the care starts later that day. If somebody doesn't have that, we'd have to weigh up that risk and make sure that everything was in place so that person could return home safely. And as Rachel had referred to, it's about safe and timely discharge. We don't want to see people returning to hospital because the reablement package has failed, the home care package, the residential package. So in terms of that planning, it has to be carefully considered to make sure that person has the best opportunity to recover at home, and we don't see that fail and needing a return to hospital.
Thank you. So yes, I wanted to be clear that we're aiming, clearly it's going to be safe, but is that as a result of an expected installation in the home or an actual installation in the home?
There isn't a blanket response, I suppose, is the easy answer, because there are so many different scenarios, and somebody may need a piece of equipment from an occupational therapist. They may need some support to access the property when they return home. We work closely with our voluntary sector partners, British Red Cross. We have Carers Plus up in the north of the county as well, who help with hospital discharges. So it really depends on that individual and making sure their circumstances are safe for them to return home, and the care package starts at that right point. Some people have medication needs, so it would have to be timed appropriately. So it really does depend on that individual circumstances.
Thank you very much. Yes, they are. Everyone is different, no doubt. Thank you.
Thank you. Anyone else? Councillor Blakeson, would you like to come in? Welcome to the committee.
Yeah, thank you. And please bear with me. This is my first first appearance, and apologies if what I'm going to ask is contained somewhere in the information. I've tried to digest it. It kind of follows on from Councillor Walker's question there, and I'm thinking about sort of elderly and more frail residents who are admitted to hospital for treatment and then discharged back to home following, obviously, the assessment. Do you have any data available in terms of that type of patient that looks at subsequent readmission and how soon that might be after being discharged? And also any sort of additional demands on GP services which may come about because of being discharged from hospital, but still either through loneliness or through frailty or illness, tend to contact the GP more regularly than you would expect.
Thank you, Councillor. In terms of that cohort of patients, it's not specifically written within the report. However, what I can share is for a whole trust perspective, the readmission rate is, or previously was, 8.1%. So 8.1% of patients were readmitted within 72 days. That was a key area of focus for us nearly 12 months ago. And we implemented a voluntary sector service which looked at trying to support people once they left home to connect with things in their community, be that voluntary services or general practice or other things. And I'm pleased to say that that readmission rate has now dropped to 6.1%. So there is a difference. Specifically, the high readmission or the higher proportion of that readmission rate was not frail elderly. It was actually younger people who were perhaps experiencing homelessness or other substance misuse issues that were predominantly within that readmission sector. Additionally, East Riding as a local authority performed very well where people do receive reablement and are then still at home 91 days later, and that's a marker that's described in the adult social care outcome framework, and they are one of the highest performing councils across the country for that cohort of patients. So in both those instances, I think we could describe a population that is well supported when they leave home. In terms of the input from a general practice perspective and the integration perhaps between discharge from hospital and returning to the community, it is something that we would like to improve and address. What would currently happen is a patient would be discharged to services with local authority if there was the requirement for additional community nursing perhaps or additional community health services, then those would be referred to at the point that a person leaves the hospital. However, and as is often the case, people can return home and then become quite poorly and need general practice support, and that would be arranged as would usually be the case. Somebody would contact the general practice. What we do want to do is make sure that there is a better connection between discharge and general practice so that the GP who has known the person and supported the person in the community is more aware of why the person was in hospital, what perhaps might have changed, be that medication or other things that might need that longer term view. And we do that currently through a discharge letter. So it's a summary care record effectively from hospital that is sent to the person's GP. It doesn't necessarily contain the detail that we'd like it to, and that's an area that we'll pick up moving forward so that there is a greater or an improved transition, I guess, from hospital into general practice and community services.
Just a quick quick follow-up, if I may.
Yeah.
So the discharge rate that you just outlined there and the discharge letter to the GP and so on, are you speaking from a perspective of the whole hospitals? Is it fair to say that discharge rate, that readmission rate, sorry, and those processes are in place, say, for East Riding residents going into a York hospital?
The general process is pretty much the same across, consistent across the other hospitals. In terms of readmission rates, I don't necessarily have those specific figures, but as an East Riding population, that reablement figure would apply to any of the other hospitals. So there are a high majority of people who stay home after they receive reablement support. And whilst I particularly focus on Hoth, the discharge letter is something that we're looking at across Humber and North Yorkshire wide, so that we can improve that across all of the hospitals, regardless of population served.
Okay, thank you. Next we have Councillor Kristen White.
Thank you, Chair. Morning, everybody. So, not to be doom and gloom, but I am thinking winter is coming. So we're going to have more admissions into hospital. We are going to have staff going off on sick because they're obviously going to catch colds, etc. And therefore, what is your winter resilience plan to the fact that you're coping with more people going in who are then being discharged, but you've also got staff going off on sick? Thank you.
Thank you for the question. So it's a very timely question because we're in the throes of our winter planning at this point in time. In fact, we're finalising our documents that we share with partners. A colleague's working on it this week, actually. So we're very mindful of that. And in terms of the hospitals, they start way in advance, like the middle of summertime, they start their winter planning. But for us, in terms of that staffing cohort, obviously we have a set staff group that cover the hospitals. However, we work with the ICB in terms of enhancing that with additional resources. So we have had funding agreed to have some additional staff in place to build our resilience there. Unfortunately, there are situations where flu, viruses, etc., do impact on our service, and we have to adjust accordingly. But with our staff, that's one of the things we look at. We also look at what beds we may have available, and Bridget will be able to comment more on this. We look at our brokerage offer in terms of how quickly we can identify those placements. So there are a number of areas that we look at to ensure that we're as resilient as we can be going through, even things like making sure that flu vaccination, you'll see posters up around County Hall encouraging staff to have their flu vaccination, just to make sure we're fit and well going into that winter period as best we can.
Bridget?
Yeah, so from a provider point of view and for resources, we've worked with our both home care and care home markets. So what we've done this year is slightly different. You typically would buy a lot of beds, but they don't always get filled. And so what we're doing is putting a slight caveat into our standard terms of business for our providers to invite them to have an enhanced rate for a discharge from hospital for a fixed period of time that would then convert to either a temporary stay or would go into our normal processes. So we're not paying for beds that aren't used, but we're saying we'll pay you more when you discharge someone, and talk to us about your terms and conditions, meaning when can someone be discharged? Is it nighttime? Is it only daytime? Do you do weekends? So we've got that sort of information to fingertips. Home care wise, we have to work from now with our home care market. It's quite soon that we start to finalise rotas and capacity, because what they will do is then the terminology being sort of locking down of rotas. And that just means that we then have our absolute know what our capacity is going to be over that period. That's what we're still working on. We lock it down to allow it. So it's one thing to say we've got people coming out, we need X number, we're predicting, and we try and buy in or lock down a little bit more. But obviously our care market are also entitled to their Christmas breaks and winter breaks. So it's that particular period over Christmas that is where we manage that home care market quite precisely. But typically we're working to buy as much of the market as we can. We do still have pockets of areas and localities that it's harder to source. So that is recognised with some of our stats here as well, that you'll see. But that is something that the commissioners are working on currently and will continue to do so.
Yeah, just a little wiggle. Oh yeah, Simon, did you want to come in first or?
Yeah, it was just on the winter issue. Slightly broader than the scope of the subject, but this week the ICB and the NHS providers are required to sign off their winter plans. So they are and colleagues across a range of agencies, including colleagues from the local authority, have been actively engaged in developing those plans. So I think in terms of the issue about responding to winter, it is clearly broader than just the issue in terms of discharge and planning. And some of this has already been mentioned. I think there is a great focus and need around vaccination. As colleagues will be aware, the biggest driver on hospital services typically over winter, particularly in January, February, is around respiratory admissions, often people who've got pre-existing conditions. So there is a need for us to be as active as possible. And this is also links into colleagues in public health around vaccination, also management of multimorbidity, and trying to keep the population as well as possible. So if we can avoid admission, then that reduces the need for discharge even more. So there's a lot of work around the winter plan, and we're happy to share that with yourselves once we've just signed that off this week. We mentioned about staff, and I think it's also important to recognise the impact of childhood illness in winter, not just directly, but also the impact on staff. You know, often having children who are ill or in rare, but on those occasions where school closes, that often has quite a big impact on care staff. The last point, I think, is where also my request is just that we work as actively with colleagues in the local authority around making sure we can minimise delays across the pathway. So I think we did see last winter at times periods of quite extended delays waiting for social care allocation, and that clearly before someone's even allocated a social worker, they're not going to get discharged if they need a package of care. So although we recognise there are pressures across the staffing system, reducing those more administrative delays would be really helpful.
Thank you, Simon. Andy, did you want to come in on that point?
Just quickly, Chair, just to answer Councillor White's question, in terms of winter, that the nightmare winter would be where we get a whole bunch of infectious diseases all hitting at once. So we had COVID, flu, RSV, all peaking at the same time, and that putting pressure and closing down the system. The way to stop that is to get people vaccinated, COVID, flu, RSV, whilst at the same time dealing with outbreaks. So when you do get cases in a care home, for example, they are managed quickly and controlled. Big issue is probably convincing staff to take the vaccine at the moment.
Councillor Kristen White, you want to come back in?
Yeah, it was actually then a question for Andy. So of the people, or maybe it's not, for the number of people that are actually admitted to hospital, what percentage were vaccinated or what percentage are vaccinated? It's whichever way around you want to tell me.
It would depend on the particular infection and the vaccine. The flu vaccine is probably around 50% protection. But what I would say there's the admission, but then it's reducing of the symptoms as well. So it's whether people go over that threshold where they need support. So you could have a bad flu or a bad COVID, but you can deal with it and you don't need respiratory equipment or you don't need a nursing bed. It's the most vulnerable, and we found that during COVID, where people have multiple long-term conditions, where it just tips them over the edge, and that diabetes gets worse, or that respiratory problem tips into requiring oxygen. So I think that the vaccination we know reduces deaths and it reduces hospitalisation. Depend on the strain.
I think I'm asking, how do you know? Because then I did ask what would be, if I said today that there were 100 people admitted to hospital today, of those 100 people with some respiratory condition, how many had had the vaccine? Because I'm trying to work out whether our campaign to get people vaccinated is doing what it should be. Because if you said to me, of that 100 people, only 30 were vaccinated and 70 were, I'd want to know why the 70 were and why we weren't getting the message across that those 70 needed to be vaccinated. So that's why I'm asking for more specific figures.
I can get you the specific figures, but it really depends on the particular infection at that time and the different. So RSV would be different from COVID, be different from flu, and they would differ each year. So this year's flu vaccine is different from last year's vaccine. But I can give you the figures from previous, which again do show the numbers that. So in terms of childhood vaccinations, we know it's incredibly high level. We don't have measles problems at the moment because we have such high levels of vaccination. If we didn't, if that dropped low, we would see lots of children ending up in hospital.
Thank you, Andy. Maybe that's something that you could, send round when you've got time to update us on that.
Yeah.
I'm just conscious of the fact that it's not actually in part of the report. So, but it would be useful to know if you could.
So in terms of the efficacy of vaccines, depending upon the infectious disease.
Yeah.
Yeah.
Is that okay? Thank you. I just wanted a little wiggle on Bridget's point when it's quite interesting what you were talking about, the way that you're looking at discharging and having a different system. I was just a little bit concerned about the possibility of sort of late night discharges for particularly elderly people or people that don't have support to get home, because I think it's great that you're trying to look at different ways and get people out of hospital quicker. But we hear horror stories, don't we, in our wards of people who have been sent home in the middle of the night, in a taxi and costing £100 or £50 to get home. So I think that's got to be taken into account. I'm sure that will be from your perspective, but I just wanted to highlight that as a concern of mine.
I absolutely agree. And so the discharges that we would see, what I would count more as out of hours, would typically be if someone is going back to their own house or back to their own care home. So someone knows is ready to accept them. You wouldn't be able to discharge someone to a new care home out of hours. That is just wouldn't happen. You have to have that they're properly welcomed. There's a process that homes go through for it. And again, if someone was suddenly able to go home and family aren't available, it's what can we put around that person? So you've got to be very pragmatic about it. So yeah, you're right to raise the concerns, but it happens when it's appropriate to happen, rather than it's not a blanket approach. Yeah.
Waiting patiently, we have Councillor Boynton and then Councillor Cousins. Thank you.
Thank you very much. Just picking up on Simon and Rachel's points, really. So Simon mentioned kind of administrative delays, social workers maybe not being allocated on time. Rachel, you mentioned about the brokerage system that pops up quite often over the years. We've heard issues in regards to this system. Internally at East Riding, if those two systems can get sorted, then surely these numbers will fall down. So I suppose the question is, what are the delays? What are the reasons for the delays in allocating social workers at first point of contact? And the second question is the brokerage system. Again, we've heard over a number of years, we've got issues, it's sorted. We've got issues, it's been sorted again. And I kind of struggle with that one a little bit because it's a system. It's something we can alter, and surely there's a kind of set processes. But I'm sure it's a lot more complicated than that. But can you give us a bit of an understanding of what those are, and if we can get those two systems sorted, Chair, I think hopefully we can bring down these numbers.
Yeah, thank you, Councillor. In terms of the assessment delay position, first and foremost, that has most certainly improved from the point that we were last at the committee December last year. And previously we were seeing patients waiting 2, 3, 4, 5 days to be assessed, to be allocated a worker. And that significantly has dropped to within a day. So there's been significant progress in that position. The people that are awaiting allocation are often those with the most complex needs. So it may be that they require a best interest meeting. It may be that they're requiring support because they're at their end of life, or they have a complex need around housing, misuse issues, substance misuse issues, and that requires a bit more of a multidisciplinary team approach. So it may not be specifically an East Riding allocation delay. It may be the complexity of the case requires a specific worker with that specific skill to be able to discharge the person. But on the whole, that assessment allocation has improved and has been supported by the Integrated Care Board in the last 6 to 9 months. Now, we will continue to try and prioritise that position, but that will come under scrutiny if the funds aren't, the resources aren't available next year to continue that. In terms of how we work collectively, it's not just about putting lots more social workers in. We need to make sure that we can make our pathways as efficient as they are, so that people who can simply return to their own home or simply return to a care home can do so without the specific skills of social workers, or who perhaps can be supported by a different skilled worker. And there's a number of different approaches that East Riding have put in place to support that position. So I think on that particular issue, it's certainly improved. For the brokerage position, specifically at Hull, there has been some short-term sickness in that team, and that's caused some of the challenges more recently. I think we've also seen a position where we've relied so much on bedded services that brokerage teams has been absorbed. So I think that is perhaps why at times you've seen that system sorted, that system's now overwhelmed, that system sorted. And it's not just an East Riding position to fix. The hospital needs to make sure that they refer people more timely, that we don't have a great big kind of drop of patients on a Friday because everybody needs to leave the hospital. So there are things that I certainly pick up with the hospital directly to try and make that position more easy. I think moving forward, Liz, myself and Marianne, the service manager for the team, have already spoken about what can we collectively think about coming into winter to make sure that that team has the resilience it needs to see that period through, and we'll be able to then evaluate in terms of the demand it's experienced. Are we now confident and assured that we're seeing more people go home, there is less call on brokerage, there is less call on nursing and residential facilities. So it's an area of focus for ourselves in terms of improvement and monitoring.
Thank you. I mean, yeah, that clears things up for us. Thank you. I suppose just to follow on slightly for us, again, you mentioned about services talking to each other, timely conversations to have discharge. We've heard again in the past about Jean Bishop Centre, Rossmore, is it at Back of Hull Royal, doing fantastic work by the sounds of it. Is that something you would advocate for more, which would help you in your kind of discharge processes, really?
Sorry. Thank you. Yeah, the services that you describe are certainly supporting the people across Hull and East Riding. And what I would say is we have come together more as system partners over the last 12 to 18 months than certainly we ever have, and certainly before I arrived. So particularly for Rossmore, that service is open to anybody across the Hull and East Riding population, and the team that receives those patients work directly with East Riding. So some of the comments you made previously, Councillor Walker, about challenging decisions, actually East Riding may advocate for a person going to a rehabilitation service because it's the right thing for that patient, and we want to see that improvement. So they do work collectively together. And Rossmore is run by City Healthcare Partnership, CHCP, and they are currently going through a reconfiguration, and we met as system partners to go through that reconfiguration so that we could influence what that reconfiguration looked like, whether we had enhanced stroke services, whether we had enhanced reablement opportunities, rehabilitation opportunities. So I think in terms of assuring you that we're working together and accessing services that we have in our geography, that's certainly happening, and East Riding play a key part in influencing some of the services that are delivered in the future of those services.
I've got two people who want to come in, and then I have the very patient Councillor Cousins waiting. So we've got Simon who would like to have a comment, and then Councillor Kristen White. Thank you.
Thank you. Yes, just briefly, just picking up the issue around frailty. I think the Jean Bishop Centre is an excellent example, a sort of an exemplar of a frailty model. However, that sort of more centre-based model does work well in a relatively small, densely populated city. So I was in Goole last week, and we were talking with the GPs and colleagues about how we can extend proactive frailty management in areas like Goole, where we wouldn't particularly want people from Goole necessarily having to travel into Hull. And we do have a really active virtual frailty model in Bridlington and in Holderness, and we're looking to roll that out. So I think across the ICB, frailty is one of our 5 highest priorities, and it's looking at the Jean Bishop type model rather than just having a centre. If you can have a centre, great, but that tends to work for better and larger populations. I think I would emphasise again, I think when we talk about cohorts of people who have been discharged from hospital, it's always worth remembering what are the interventions we can make in terms of keeping people well and around prevention. So that anticipatory frailty, which in some cases will either reduce the need for admission or mean that they need, a very short admission and diagnosis, be a discharge home. Because I think what we still see is a relatively significant population of particularly the frail elderly who spend too long in hospital without that being really to their benefit. So I think that proactive, whether you call it secondary prevention or whatever, I think is really important in terms of this wider conversation around the people concerned by discharge.
Okay. Councillor Kristen White, please. Thank you.
Thank you, Chair. And I do apologise to Councillor Cousins if I've pushed in. So just thinking, if I had a social worker and then I'm admitted to hospital, I wouldn't need to wait for the allocation because I already have a social worker. So how do you communicate? How does my social worker, how do they get to know what's going on and then help me return home rather than waiting to be allocated one? Because I actually already have one.
In that situation, obviously, because we've got hospital-based staff, there's that communication there instantly. Our internal systems communicate with each other. We use the same system so we can put things through. That's all built in there. So when the referral comes in, if you like, from the hospital to the social work team, the right person would be assigned to the job. And if it is somebody outside of there, that communication would take place. I think sometimes it can be because there's an issue in terms of the timeliness of allocating a social worker. And for example, just looking at last week's figures, on one day we had 22 new referrals in Huth in 24 hours. New referrals. That's what we're saying about looking at the whole process to make sure there are no bottlenecks in that system. But you can't plan for when people are going to arrive into that inbox.
And just to be clear, when you say new referrals, that's somebody who's never had a social worker, who doesn't have a social worker. They're a new referral.
I couldn't tell you whether they've got a social worker or not. They're new to the hospital. They've come into the hospital team. So they're into the system as a new person. It might then be they're known to Bridlington team or elsewhere. But there can be those pressure points. And we can't always predict that. You don't know who's coming through the door and what the pattern of illnesses are coming through. So that does pose as a problem. But obviously, as we've heard, we use skill sets to get the right people through. The complexity of patients that we see that require social work intervention for longer term placements. We've seen some really poorly and complicated people in terms of their care needs who need very specialist placements. So that can all impact. So whether you have a social worker already or you're new to the hospital social work team, if you like, depending on what your presentation is, there are a number of factors which can then slow that down. And it may be that it's been a very, very busy day, but it might be a number of other factors and the complexity of the case and the requirement of the support that people may need on leaving hospital.
Okay, I'm sorry, you're confusing me.
It's okay.
I suppose what I'm trying to get at is if I have a social worker already, does that make it quicker then for the discharge, because you already know that social worker already knows me and therefore knows what's in my home and what needs I needed before, and obviously I might be just the same or I might need additional ones, as opposed to getting a completely new social worker. That would then take time because that new social worker would have to come in and ask me all of those questions, but my old social worker would already know.
Yeah.
So I think I'm just trying to work out, do you get allocated a new social worker because you've gone into hospital every time you go in, or do you keep the old one?
There would be, if you want to answer,
Yeah, in terms of discharge from hospital, at the point that you're ready to leave, you're referred into the discharge hub. Immediately, that would be triaged. So we would think about what services that did you have previously? Is there a relevant social worker who it would make more sense for them to continue that journey? However, there's a challenge in terms of making the service more efficient. So if you had lots of social workers coming into the hospital, that would slow the whole process down. If you have lots of social workers coming into the hospital, trying to understand the services that exist to get people out of hospital, that would also slow things down. So quite often we have to kind of manage the continuation for patients in the background, but make sure that the right person can assess them and get them home. Now, it might be the same social worker you had in the community, or it might be a new social worker, and that's not necessarily a bad thing for people who can look at different issues. Needs have changed. Actually, we need to think, we've been with the same social worker for a significant period of time, but this hasn't been picked up or that hasn't been talked about. The previous social worker would always be included in the conversation. We'd look back at previous assessments, we'd look back at previous case notes. So we try to maintain the continuation for the person in the centre of all of that, but we need to make sure that we deliver the services in the most efficient way, and having a concentrated team in the hospital who know exactly who the reablement worker is and what capacity is available makes that service more efficient.
Thank you for that. Right, we now have Councillor Cousins. Thank you for waiting.
More than welcome. It's a very important topic, and I'm more than happy to wait for good quality interrogation and questions. Talking of which, I have two, if that's all right. Firstly, figure 6 on page 14, true demand versus actual demand. I find that really quite interesting, and I'm not at all surprised that there's a great demand for home care versus other services. There is obviously a big disparity between demand and actual activity, which I understand you are addressing. What I'm interested in is that difference, the disparity, is that down to clinical requirements, people wanting home care, but clinically it isn't sensible, versus the cost of delivering home care, or the resources that we have available? And more interestingly, from what Simon was just saying, rurality. We have a hugely rural patch. From information we're receiving from central government about taking away that measure on funding, we're going to have less money because we're rural rather than more, which is just appalling. So I was wondering what the limitations are, what's your big problem, why the disparity, and a little more explanation over what we're doing.
Thank you. Yeah, the significant challenge is the availability of resource. So it might not be available today, but it may be available tomorrow because somebody else is being discharged, and we can move those people onto the actual caseload. And often people may have to wait too long for that package to start and be available. So I think in answering the first part of that question, it is availability and it is resource that needs to be improved in order to meet that true demand. In terms of the challenges, and I'll certainly look to colleagues in the local council to describe better than I the position around rurality and the specific geography, but certainly in my position, I see that kind of helicopter view of being able to discharge people. And if you live in a more rural area, it will take longer to arrange home care, and we should be able to address that. And you've rightly articulated the challenges of funding and what that means for this particular area. We try to deliver the services equitably. So if somebody is waiting in a rural location, they are waiting in a rural location, we'll look to deliver those services. But that is not always a possibility. And we do find that people waiting for a complex care package in a rural area may have to wait longer than others who aren't in a rural area. And it's certainly something we would want to improve, but I'll ask colleagues to step in terms of any specific.
It's always difficult to, if you're talking high level need and complexity, typically you're talking 2 carers needed at any one time. And there are typically, you have what we call double up runs, so 2 carers in that as a rota. So if you're looking to identify one more, you have to usually find the space within a rota or capacity within the staff who are currently on that rota to deliver more, if that's what they're trained in. So it isn't ever quite as easy as just having the capacity, which you may have. So we do struggle to sort, as you've said, I can't disagree with anything you say, Rachel, with the more rural areas. But then it's the timing of, as I've said in here before, about travel to the location, as well as getting the rota capacity and staff. If you then add a double up run onto an ordinary rota, you're going with someone who's got singles. They're just going singly, and then they've got to meet up to do something. So it sounds silly, but it's the timetabling of it that is really quite complex, as well as having the right number of staff available to do it. I'm not sure if that quite answers your question. My mind sort of went into that zone.
On double up and singles and person-centered care, those are terms that she would kill me if I used, if I'm brutally honest. It does beggar a question around timing and travel, in that if you have somebody that needs 2 people to help, to aid, do they still get, and you've got, I don't know, a half an hour allocation. Does that mean they have 2 people for 15 minutes, or are they still there for half an hour? Because I have heard of that before.
If it's 30 minutes, it's 30 minutes with 2 people. Yeah.
Okay, so really we do have challenges around resourcing, both from a cost and personnel point of view, with delivering person-centred home care in a rural location. And we really ought to have something at the end of this as a way out of what we can do about that, because I see that as a real absolute issue for this county. My second question really goes into the fact that you're an amazingly calm and measured team that obviously are doing really well. However, I find myself wondering what the issues are. The report is also balanced, measured. But, you know, it doesn't matter how much makeup you put on it, a pig is still a pig. And at the moment, given resourcing with the NHS, this is about the NHS emptying beds as fast as possible and giving that responsibility over to this local authority that has a mandatory obligation to deliver services that they're not delivering in hospital. So I feel really sorry for the brokerage team. I do know of information where patients, what they're presenting coming out of hospital has been basically lied about by the NHS, whether it be the fact that they forget to say they've got Hep C, they forget to say that they've got diabetes, they forget to say that they're grossly obese and require specialist equipment, and still arrive at a care home out of hours because the ambulance service haven't been able to get them there in time. That's not your issue. It's your issue because you're taking people from all of these hospitals that are desperately trying to free beds. So I find myself asking again, instead of having a lovely, this is what we're doing great report, I want to know what we can't do because we don't have resources, because central government is limiting the money, or because we're not delivering properly, or what we can do as a council to help you deliver for our residents. And there must be things. You can't sit there and think, yeah, no, it's all fine, we've got everything we need. I want to know what we can do, what's wrong, and how we can help you, and what we can do as recommendations to take that forward.
Thank you. I'm conscious that Simon did want to come in and we have his name down, so I'll just let Simon come in first of all.
I think I'll respond to that, I think, because it also covers across what I was going to say to some extent. So I'll try and be brief. Firstly, my understanding is that, one of the, with all due respect, I'm obviously not here to tell you what your jobs are, but one of the functions of politicians is to campaign and represent for their populations. So, I have a slight conflict of interest, not directly here, but my wife is a district nurse who works just outside Scarborough. The distance she travels potentially for her patches is wider than the span of the city of Hull. So in a normal day, she would be doing, and that's no disrespect to the people in Hull who work really, really hard. But I think there is an issue about just the issue of rurality, which does get ignored. And it is just, it just does physically take you longer to get from, even working within localities within the East Riding are often larger than some of the cities. So I think there is a need to just continue to campaign for that. I think I would have to pick up on the phrase that you used about either care homes or social workers being lied to by the NHS. I think I would request that comment is withdrawn. I think there are situations where information is badly communicated. There are situations where communication is done in a haphazard fashion, or when systems, and particularly when hospitals are under severe pressure, sometimes things are missed. I would be, it's a negligent action, and it's potentially one that would involve a nurse being struck off if she deliberately told a care home that somebody had an active infection and they were telling them that they didn't. So I think the phrase lied, I think, is going too far, really. So I think we have to sort of, as this is a public meeting that's cast in on YouTube, I think I'm not sure there's any evidence of active lying. There is, I accept there are evidence of poor discharges, and there are examples where we need to learn from that and do it better. And I do think that is something that unfortunately often happens more frequently in late evenings and weekends. So I accept that discharge is not always perfect. I think in terms of what we can do, we do also probably have to recognise that in various periods of COVID, the number of delays from hospital were much less, partly because there were designated funding provided from national government, which funded the first 6 weeks of people's discharge, and that was provided. That funding is not available to either the NHS or local authorities. And I think the other point I have to recognise is that there really is a limited opportunity for the ICB and Rachel and myself and people to put a huge amount of pressure on the Director of Social Services and the Council just to provide more social care capacity. We do need to understand what can be provided. The more strategic point, I think, is what can we do in terms of early intervention and prevention? Because I think in terms of managing the onset and progress of disease, and I've mentioned prevention 3 or 4 times today, but there's always a public health angle to this. I think secondly, East Riding, if you look at the bed tracker, actually has a lot of care homes, many of whom have empty beds, and it seems to be a relatively active and worthwhile market for a number of providers. Now, on the assumption that there's only a limited number of staff who want to work in the care sector, we need to probably think collectively about how we shift some of that resource and capacity out of bedded care homes and into more domiciliary care. And that's something we collectively need to do to shift where the costs in the system sit. Because I don't think either the NHS locally or East Riding Local Authority suddenly get a massive wad of money. We might do, but I think that's probably a bit optimistic. So we need to collectively think about how we shift the emphasis of care more into the home, which we have done in a number of areas. We've done it with mental health, we've done it with palliative care, we are doing it with social care, but and rehabilitation, but we maybe need to do more of it. So apologies, that was quite a long intervention.
Thank you, Simon. That's really useful. I'm conscious of, sorry, I think Andy wanted, sorry, is it relating to the Simon?
Yeah, I just wanted to apologise that I will happily withdraw the term lying. I think it's probably more along buyer beware. If you don't ask, you're not necessarily told. And so I'll happily withdraw that.
Thank you.
Andy.
Thank you. So just in terms agreeing with what Simon's saying now, in terms of we definitely need to shift towards prevention, and that would be reducing frailty or dealing with frailty, helping people deal with chronic conditions so they don't get worse and they end up in hospital, and then helping carers when relationships break down or the pressure on them is too high to maintain that caring relationship. It's the capacity of caring in the community. And if you look at figure 7, the projections are that the current workforce will need to be doubled to meet that need. Now, who's going to do that? Is that going to be paid and people with badges, and whether it's NHS or the council, or is it going to be people in the local community, in that local village, providing that support? And how do we shift towards that community capacity? And what's that relationship with our voluntary community groups, but also just generally with good neighbour schemes as well? So I think that there's a shift here into expanding care, and care being preventative care to stop things getting worse, and then carers themselves being supported so they don't end up just tipping over and then requiring people with badges to look after people. So I think it's prevention isn't just about stopping it happening, it's when it's happening, how do you stop it getting worse? Then when it's got worse, how do you get people back to a state of independence, or at least functioning in their community? So I think it's a more nuanced approach, but the emphasis is always when there's a crisis to shift into treating people and pull people out down the river. We've got to stop them falling in, then stop them falling in again and again and again.
Thank you, Andy. Councillor Owen.
Yeah, thanks, Chair. I'd say if there's one thing I would make a plea to probably this committee and members in general is to back really what Andy's just said about having a proper prevention strategy as an authority. We've talked about it many times. We've tried to kickstart it many times. Taking Councillor Cousins' point, I don't read this report as being all rosy and rose-tinted. But when I look back to where we were a few years ago, where all the arguments about bed blocking, it was a weekly battle. We're blaming each other, hospitals blaming social care blaming the hospitals, no facts or evidence to work on. It was just a constant battle of a blame game. Those days are long gone, and I'd like to thank the likes of Simon, particularly, who sometimes think he's a great ally to us, despite some of the restrictions that the NHS sometimes places on him. And so we do have those proper debates. I think the reality is we have a policy as an authority not to put people in care homes, but to keep them at home. I think we do have a mixed market in terms of that domiciliary care across the East Riding for all those rurality issues that have been made clear in this debate. And I don't think things are rosy. They are really difficult. There are capacity issues, there are funding issues, and they're going to be there. So going on that full circle, I think anything we can do on that prevention front, which was Wes Streeting's great thing, you know, ICB is going to pour money into prevention because they saw that as the only way of keeping people out of hospitals. We're on a journey. We're quite well, a lot better place than we were probably 5-10 years ago in those relationships with hospitals, but still a long way to go. And, you know, you ask what we can do as members, cross-party. I think let's really put some effort into that prevention, because there ain't going to be a lot of money around for extra social care workers. We might be able to rebalance staffing, you know, across different avenues of social care, but I don't think there's any magic solutions there or a silver bullet. So that's my plea on what we could probably collectively do in terms of a focus and a priority. But that's just a personal view, Chair. Thank you.
Thank you, Councillor Owen. Yeah, I 100% agree with you on that. I mean, I've very much pushed this preventative agenda, as Andy knows, and as members will know, we have that item in November coming to scrutiny, so that's going to be a real opportunity, I think, to put some meat on the bones, because we talk a lot about it, but I think we need to firm it up and have a proper a structure. I don't know, we'll talk about that in November, but absolutely agree with Councillor Owen on that one. So we have, I think we've just got Councillor Walker now.
Just me.
Come in.
The very large discussions we've just had have completely overshadowed. I've got one small niggle that I want to come back to on the end.
Yeah.
But on the major subjects, I think that I'd like to ask about the ongoing long-term funding pattern for this. The reason that we're here specifically was that we looked at the whole model last December. We wanted to look at the expansion of that out to the other hospitals that discharge into East Riding. And everything we've just said about rurality applies to that completely, so that we need to try and avoid that postcode lottery of access to prompt discharge and timely. But running through the report it was clear that ICB were lending significant support to this project. And I'm not quite sure, I can't remember, is it also now funded out of Better Care Fund type pot of money? And is there more talk? There was a few months ago of collaborating more on some sections of the joint budget between the NHS and local authorities. And this strikes me as an ideal vehicle where both sides need to win, as well as the patient. The hospital needs to have fewer block beds. We need to have timely adult social care in place, and the patient needs to just flow seamlessly between the two. Surely that is an ideal joint funding approach. Is that a practical possibility going forward? I just worry about the ongoing funding.
I think I'll start, and I think Rachel can also comment. I think it's interesting in terms of the points that you raise, Andy, which you can make a list or a schedule of different areas of funding, and the complication, I think, is that some of this funding is effectively core NHS funding and should be, and some of this is core social care funding and should be, and then there are other areas where it is crosses over both, and that's one of the areas where the Better Care Fund was created, really, was to support a lot of that joint working. So I think you're right in terms, and we haven't got time to go into the detail of that now, but there are a number of different pots which support the discharge process that Rachel and colleagues have talked through. I think there is a piece of work which we are sort of engaged in now, but of bringing those pots together more closely. Now, whether that's into a pool budget or not is a separate question, partly because a lot of the resources that Rachel manages on a day-to-day through the bed capacity fund are funded through both the Hull and East Riding local authorities. So some of that money is pooled beyond local authority boundaries. I think the not very specific answer to that is I think we do need to have a specific piece of work looking at funding flows. And I think it has been raised by Rachel in the report. Some of our current funding flows are non-recurrent and may or may not end. And I think we need to understand if they can end, what is managed in terms of the exit, and if we need them, how they're recurrently funded. So I think that is a piece of discussion that's ongoing. I know Bridget's had various conversations related to some of the use of the Better Care Fund. So that isn't something I think we can give you a specific answer to now, but as much as we can, we should look to try to manage this, if not as an actual pool budget, as a virtual pool where everyone's got full sight of the resource. And that was part of the driver for us looking at the additional Section 75 agreement, which we talked about earlier in the year, which has unfortunately hit some legal rocks, but we will get beyond that, I suspect.
Is that okay? Yeah. Okay. I think Councillor Kristen White just wanted a wiggle on that. Is that right? No? There's another question.
It was a wiggle off something that Simon had said
Okay,
earlier.
go on then.
Have we got time?
Yeah,
Yeah.
we've got time, yeah.
Okay, Simon, you mentioned when responding to Councillor Cousins that there was there is occasionally poor discharges, which was something I'd not really given any thought to. So thinking on that off the top of my head, we must get them. I'm assuming, I could be wrong, they are few and far between. But when we do get those, how do you talk to each other about how to make that better in the future, and review those cases? Thank you.
Yeah, hi. And yes, sadly, there are occasions where we do need to get around a table and think about how did that happen? Why did that happen? There are also occasions where people's presentations aren't quite understood in hospital because it's a unique environment and actually things are different at home. That's not necessarily that the fault lies anywhere other than there's a different understanding. Where things do go wrong, and that might be that medication, specific medication that should have gone with the person didn't go, or that might be that there's been a lack of communication between hospital and community nursing, and the community nursing team hasn't showed up to resolve bandage issues or other things. Where those do happen, we have two different areas or forums effectively that people can lodge a transfer of care concern. So I have oversight over all of them. If it was a external provider, so a nursing or residential provider, they would highlight that transfer of care concern. Most often they will ring me or they'll ring the hospital if it's something urgent that needs physically fixing in that moment, and then we'll review that as a multidisciplinary team to find out what happened, why that happened, and what we need to do to change. Most recently, the communication has been an area where we have been trying to improve. What used to happen is the hospital would complete a transfer of care, a trust assessor form. It's a long form, and they would fill it out to the best of their knowledge. That might be a very busy ward, a nurse who doesn't necessarily know the patient very well, etc., etc. What we have been aiming to do is to pass the referral on more quickly from the ward to people who do know the person, so the previous social worker or the social worker that's been involved or the community health person, so that that miscommunication or that new information is handed over more appropriately in an electronic record that everybody can see, that everybody can add to, so that we minimise that risk of not transferring important information about a weight or a medication or a plan that people need to be aware of. We also work more closely with the therapy department in Hull University Trust, so that manual handling plans, equipment issues, all of those things are better managed and better transferred over between organisations to prevent them. But in answering your question, we have a forum. That information comes back, and we'll bring people around the table to review when things go wrong and put in place things to resolve that.
Just to add just a little to that, I think the other point I would make is that hopefully, our genuinely poor discharges are few, but they do exist, and although I reject the suggestion that was is ever deliberate, but it does happen more than it should do. I think the other point is that even with those discharges that do happen, there is still a lot of work we can do to make them even better. So we do discharge people too late in the day. It's too often discharges into late afternoon and evening, which will be earlier, and the improvement of communication. I think the other thing that we're aware of is that particularly for smaller care homes, they only need one poor discharge to make them even more reluctant to take any more. So we know that there's a continual challenge from our hospitals, which is we struggle to discharge people into care homes at weekends. And the two reasons for that, one of which is they often do not have senior staff on to accept people. As Bridget says, it's not just that you turn up, you actually have to be introduced into a care home. The second issue is if a care home has had a bad experience of an admission and a discharge, they are very unlikely to take them at weekends. So it does have an impact on the NHS. So all I would say is I think that the process of discharge is multidisciplinary. We all need to work together in terms of how we plan it and improve it.
Thank you. You're okay. So Councillor Walker again.
Sorry, just to pick up, it's a small item that's been niggling away. Could I refer you onto our agenda, page 13. It's figure 5, and it concerns the no criteria to reside position for all delays across all organisations at Hull. And there, this graph only works well in colour, and for those of you with black and white, that's just tough. Because right on the end, the most recent information, August and September there, have a lot of amber dots on the end of them, with a rather cryptic message that the emergency department seem to have changed their way of working. Up until that point, we can see some good blue dots coming in there for distinct improvement. We're getting below the line just before there in May, and then all of a sudden, the ED have changed the way they're working, and you're not quite up to where, not up to page 1, but goodness me. Is that a blip? Is that the subject of, I understand these will be discussions with the provider. And does it show that all of this great work that you've done throughout this report, and the trend is definitely all going in the right direction until someone else in the mix has just changed that? Could you help me explain that? Thank you.
Yes, certainly. And whilst the no criteria to reside number is a metric, actually, how many people come into hospital, how many people need discharge support, lots of things affect what that number may or may not be, which is why it describes the emergency department, because that is a key issue for us in terms of them doing things differently. To give you a bit of detail about what that change was. So previously, the hospital may have held a person in the emergency department waiting to move to a bed, and there may not have been a bed available at the time the person needed to move. They began to move people into temporary escalation spaces at ward level, and the discharge would then enable the person to move to a bed. The person would go to the patient lounge. So effectively, the emergency department were sending people more frequently and more timely to the place where they needed to be. That meant that there were more requests for discharge support, and particularly over that specific period. So in the lead up to that change, we all worked collectively and knew about it, which is exactly where we should be. But we did see a huge volume of requests for discharge support in preparation for the emergency department moving people more speedily through the emergency department, which is also the right thing to do. So that's what predicated that particular spike. We've also seen the recent months of summer to be a particular challenge, respite requests and those things taking much longer than usual, people being off during the summer holiday, therefore not being able to provide care hours. And that's kind of created a bit of variation in where we are. We have in the last few weeks, so this report describes a figure of just over 100. We are currently sitting at 84. That was the position yesterday. So we are back to where we previously were, and that's been a sustained position over the last 3 or 4 weeks prior to this report being prepared.
Very sorry. Thank you.
Thank you, everyone. I'm conscious of the fact that we have Kim Curry with us, who's our Executive Director of Adult Social Care and Health. Welcome to you. We can't see you, but I know you're there, Kim. Hello. Ah, there she is. Hi.
Hi, yes, I'm here.
Hi, I just wanted to just ask a question which is quite related to your job, really. With my concern is the demand growing at 6% year on year. And how realistic do you think it is that workforce and provider capacity can keep pace? Thank you.
I think we've got some work to do to understand demand and capacity. And that's some work that we are kicking off post our CQC assessment, because to answer that question accurately, we really need to understand what demand is coming through in greater detail, and also what our capacity is to meet that demand, and then to make sure that our resources are in the right place. And until we've done that piece of work to understand that, that's a difficult one to answer. because we also have to be mindful, knowing that resources are tight and the council's financial situation is not going to get any easier in the coming months and indeed the coming years, that we're using our resources and the skills that we have in our workforce in the best way possible. So at the moment it would be probably a little bit too premature for me to say yes or no, because we do have that work to do.
Thank you. And so do we kind of have an estimate of, I know this is putting you on the spot, but this comes up a lot, doesn't it, at Health OSC? We talk about problems in the workforce, and I know we have been doing lots of work really to encourage more staff to come and work with us, and I think we've had limited success. So I suppose the question I'm asking is there kind of a target for when we can say that we've achieved the outcome that we want? I respect the fact that it's a very difficult task, but it's just because it keeps coming up all the time. Thank you.
No, that I can't answer that question at the moment. We will be doing some work with an external body to help us to really capture demand and capacity and make sure that that's accurate, because it is actually quite a tricky job to do, which I think is probably why it's maybe been started in the past and not completed, but we're determined that we get on top of it this time. But at this moment in time, we don't know how long that's going to take.
Okay, thank you. We don't have anyone else with questions, so I think Councillor Owen, if you'd like to give us a summing up, if you would like, before we go.
I don't think I've really much more to say than's been said around the table today. I'd like to thank everybody involved, particularly producing the report, but the way things are moving, and I think Kim summarised it, you know, there are lots of pressures ahead. We are working on to fully understand capacity moving forward, allocation of resources moving forward, and that will be an ongoing job. So, you know, I still refer back to where we were 2 or 3 years ago, where we are now, and keeps keeping that trajectory going. But I think there's been a lot of very, very valid points raised today by people around the table, and none of those are going to go away in the short term. So I have nothing more to say at this point. Thank you, Chair.
Thank you very much. So that would conclude that section of our meeting today. I think we need to go to recommendations because we seem to have quite a few. So I'll leave it to you, Rob.
Before I come in, was there anyone who wanted to raise anything specifically? Because there was a Councillor Cousins, you raised about the challenges of delivering that home care in the rural location, but for want of a specific recommendation other than acknowledging that, unless there was something.
I think maybe whether it's appropriate or not, we ask for a letter to be written to Wes Streeting, pointing out the fact that rural locations are badly impacted by delivery of home care, and additional funding should be sought or given, should be recognised rather than taken away, because we don't have that measure anymore.
Yeah, good point.
Yeah, we can certainly do that with we'll get it out to officers first and then copy in our members.
Do we have any more? I know we've had a lot of talking and a lot of discussion about this, but anything else we want to, Andrew?
The other thing we talked about obviously was prevention, and I think this is incredibly important. I understand that we've got this on the timetable for November. Talking from what Councillor Owen was saying, there has to be a motion comes out of that November meeting at the very latest. And I don't know whether that's something that we can create in that meeting, Rob. But what we ought to do is have a cross-party motion comes out of that, looking at prevention, our prevention strategy, and enabling officers to develop that.
Certainly, we can do that. It's not. I don't think there's a problem with that, is there, Rob?
Certainly, you can recommend what it'd be like. However, it should come at the end of the item. But yeah, certainly, if the committee are minded to recommend a proper preventative strategy is developed, then that's absolutely fine. But again, we'll we'll
Shall we
leave that for
cross
the next
that
meeting.
bridge when we come to it in, or do we need to note it now or? not?
No, we can pick it up next time, but we'll include in the minutes the consensus around the
Yeah,
balance of.
Councillor Kristen White.
And just that Andy from Public Health said he would get us those figures on the number of people who were vaccinated who were hospital admissions, because again, that might help us later on in the year with the prevention, knowing whether we're getting through to enough people to get vaccinated.
Oh, not got my mic on. I would like to thank you all so much for coming. It's been a very, very quite intense, I think, subject, and I've really enjoyed it. I think we've asked lots of questions, and so thank you to Simon and Rachel and Bridget and Liz and everyone who's, and of course Andy who's contributed. We look forward to seeing you again at our next session. Thank you. So I think, Andy, you're staying. Simon's staying, sorry. Get it right eventually. I'm just wondering, do people want a quick toilet break or how are you feeling? I'm just conscious of people needing to go to the, yeah, just 5 minutes if you need to. Oh, you all right? Right, we'll just get back to it then, everyone, please, because I'm conscious we've gone over a little bit. We go on to our next subject, which is pathology commissioning optimisation, and we will receive a verbal update from Simon Cox. Thank you.
Thank you. Yeah, this will be, you'll be relieved to hear quite a short item. So the ICB, as part of an overall programme called Commissioning Optimisation, is looking at a number of areas that it wants to do a sort of strategic review and start to change how it provides some of its services, so, or commissions its services, I should say. So one of them is around pathology. So we recognise that there is quite a large variation in terms of how people access pathology services, things like blood tests and a various range of services through the pathology services. And some of that variation is warranted, some of it appears to be unwarranted, and there are different rates of testing. And also we recognise there are different ways in which people access tests. We introduced this year a new enhanced service with GPs, so people can, within a diagnostic enhanced service, which will include a range of services, and also restarting phlebotomy in general practice, which was one of the things which a number of practices withdrew from as part of their industrial action last year. But that, I think, also then provides the potential for even greater variation. So this is a programme of work that we have kicked off now in terms of understanding what pathology tests are provided, where are they provided, and what's the evidence for those, and what's the most efficient way of providing them. There is now a working group set up with Scarborough, Hull, York Pathology Services, sometimes shortened to SHIPS, which is an integrated piece of work between the hospitals in Hull, Humber Health Partnership, and York and Scarborough Trust. And that's working with a working group working with GPs to look at the access and tests around pathology. So I think I'd shared the overall programme of commissioning optimisation with Councillor Phoenix as OSP chair. And I think we will bring further updates in relation to that. But at this stage, it's really just to note with you that there's a piece of work around pathology. And within that work, I think we'd also be looking to get engagement from partners just in terms of getting some patient feedback in relation to things like access to pathology. But as I say, it's a very short item at this stage.
Councillor Control.
One of the things I noticed with blood tests, and I don't understand, if you go to Hull Royal, for example, and if you're a kidney patient or something, they will do a blood test. They'll say, I'll pop down there and have a blood test today. And I'm often wondering why GP surgeries can't offer the similar service, so that you could have a blood test. If you've seen a doctor, he might say you need to book in for a blood test. Why can't they have a system similar, whereas after you've seen the doctor, you go and have your blood test, so that you're only making one visit? Because often we're finding that you have to wait another 2 weeks to have a blood test. So you've got to go back to the surgery and have that blood test, and then go back again to get the results of it.
Yes, I think that's one of the issues we need to pick up within this. I think it will, I think, vary from practice to practice. One of the potential benefits of larger practices is they have more access to things like phlebotomy staff and phlebotomists who can do those tests. Smaller practices, sometimes it's more of a challenge, and often their phlebotomy staff will already have clinics that are full. But that streamlining of access is another thing that we'll be looking at within this programme to reduce that. I think what you are identifying is that we are aware from time to time there are patients experiencing multiple visits, and the more we can reduce that, the better. Really, I think there's an approach that we used to promote in the NHS about 20 years ago about trying to do today's work today. So you come in and try and have as much done in a sort of one-stop shop. So it's not always possible, but it is one thing that we will be looking at. Yeah.
Yeah, I think that's really a really good point, because with my GP, I've been quite fortunate actually that I've gone there for an appointment and they've said, can you come back in 2 hours? Which I obviously had to hang around for 2 hours, but if you can get all the healthcare problems sorted in one day, you feel like you've achieved something, don't you? So, yeah, very good point. Have we got anything else we'd like to ask? Or no? Oh, I think Councillor Cousins has got a question.
Sorry, it wasn't really, it was a comment over my GP has, I think, 8 doctors and probably 1 phlebotomist. So it's often not possible, and there is massive waiting lists for phlebotomy. Some of the drop-in centres that happen around York, where you get given a letter and you just go in either for a scan or blood tests, work really well, but obviously you have to be mobile. But they've, you know, certainly helped me an awful lot. I think those drop-in centres are fantastic, but not greatly helpful in a rural area, really.
Thank you. Okay, so, oh, Councillor Blakeston, sorry, I didn't see you.
No, that's fine, thank you. Just to, from my understanding, really. So I've got residents in Driffield, for example, that can no longer have blood tests done at the GP surgery and have to go through to Bridlington. And clearly, you know, for elderly residents particularly, or those without their own transport, that creates a logistics issue. As I understand it, if it's the doctor's practice that have called for the blood test, then they can provide it at the surgery. If the blood test has been called by, let's say, a consultant at the hospital for ongoing care, then they can no longer do that in the surgery and have to go to Bridlington. Is that the type of thing that you'll be looking into?
Yes, that would be included within that. I mean, I think that there's a general principle, which is that the person who orders the blood test has the responsibility for the result. So there are situations where GPs and primary care colleagues will be unwilling to do tests on somebody else's behalf. So we saw it quite a lot in COVID, where patients obviously couldn't access hospitals or whatever. So because there is a responsibility attached to the result. So if you test somebody and it comes back with a result that's abnormal, the person who's ordered the test then has to do something about that. So therefore, there are situations we have shared care protocols, and there is now this new enhanced service where practices can do tests on behalf of the hospital, but we have to be clear in terms of who is responsible for the result. What we need to get, and I think you've indicated issues in Driffield, is greater consistency. So in theory, everybody really should have access to the same level of support through their practice. So this is one of the things we'll look at. And I'm happy outside of here just to pick up any specific issues around individual practices.
Councillor Crystal White.
Yeah, again, just coming back to rural practices, how are you ensuring that the like the turnaround on like those blood tests or the actual pickup of those samples, if you're a rural practice, is that much slower than if you were, say, in one of the bigger places like Bridlington? And how are you tackling that, please?
It's a good question, and I don't think it is, because I think there is transit for tests from all of the practices into pathology services. So, and I think it's in terms of the tests that will be done in general practice, the speed at which people need results is not within minutes or hours. So clearly, if you're in an emergency department, you might need a blood test really quickly. That's not likely to be the case in general practice. So I will double check, but I'm not aware there are any issues in terms of actually getting samples from rural areas. I think it's just known that we've got a big area to cover. Again, it's another area, if we're honest, where it does increase costs for people providing services, but I don't think that's an issue.
Are we all done? Any more questions, anyone? For Simon? No? Well, thank you, Simon, for that update. That's really interesting, and it's been lovely to see you again. Look forward to seeing you again soon. Thank you. So we've just got our committee work programme section to do. Rob?
Thank you, Madam Chair. So Members will recall that we did have an item scheduled for this meeting on loneliness and isolation and how that links in with the third sector. Unfortunately, we couldn't be able to get that report signed off and finish for this meeting. So we are looking to reallocate it now. Members will recall who was present for the pre-meeting. The suggestions was either the preventative item we've got in November or later on in the work programme to the mental health item, which sits in April's meeting. I had a quick chat with Andy before the meeting and agreed maybe look at the mental health, but again, it's members' work programme, entirely open to yourselves.
What do we think? Yeah, I'm happy with that. Anyone else?
Yeah, well, it's a tricky one because the preventative item scope's enormous as well, so it's but
Yeah, I think that would be fine if we can do that with the mental health. Yeah.
yeah, that's no problem.
Oh,
Maybe if we could start at 9:30, if it's going to take a little, more on it. I don't know.
can we do that? We have our brief, don't we? Our briefing before, so that would mean bringing that forward even further. I suppose we could cut the briefing from 9 till 9:30, but then would that mess up everything for you, Rob? I don't know.
I don't know. We've done bigger topics, I think, within 3 hours. We'll have to see what we're looking like, but I think we should probably be able to squeeze it into 3 hours.
Okay, so we'll keep it as is then, if that's all right with everyone. And I think we've covered that. Thank you. So there's just the last section on the agenda, which is item 6, which is our forward plan of key decisions.
There's no updates, Madam Chair.
Okay, well, that concludes our meeting for today. Thank you, everyone, for coming and contributing.